Regional Medical Center. And on behalf of our board and the many co-sponsors of this event, I would like to welcome you here today. The slides used in this presentation are available and can be emailed to you. Anyone interested, there's a sign-up sheet on the back table, and we'll be happy to get those on the email to you as early as tomorrow morning. I also want to give a special thanks to Amarillo College for the complimentary use of this beautiful auditorium. We certainly really appreciate it. Our speaker today is Ann Dunkelberg. She's the Associate Director of the Center for Public Policy Priorities in Austin, Texas. Ann is a recognized expert in the new healthcare legislation and is with us today thanks to a grant from the Robert Wood Johnson Foundation. After approximately an hour and a half presentation, you'll have the opportunity to ask detailed questions. And we encourage you to do that. We'll have someone moving through the audience with a microphone so that all should be able to hear. And please join me in welcoming Ann Dunkelberg.
Good afternoon, and thanks, Mike, for that very kind introduction. Hopefully this is loud enough, but it's not ringing in your ears yet. Hopefully we can keep it that way. Okay. Those of you who are not familiar with Center for Public Policy Priorities, we were founded in 1985 in Austin by a group of Benedictine sisters who had their monastery and still have their monastery in Bernie near San Antonio, and we were just one of a number of ministries that they set up with the goal of providing improving access to health care protections. And the center has a broader mission than just healthcare now, and it has actually since about 1990. But my job at the center has always been to work on healthcare access. So I tell you that by way of saying I do not come to this presentation without bias. You know, my bias is someone who spent about 20 years working on improving access to care for Texans. Let's see if I can figure out how to make this work now. Oh, that's good. Okay. There we go. Now I have everything I need. So, as was mentioned before, I just had to get my advancer going where I can see it. Okay, so Robert Wood Johnson Foundation has given us a grant to work on healthcare reform issues, and we had some support from them before the bill passed last year. And after the law passed, one of the things that we decided would probably be one of the best things that we could do with their support would be to go to as much of Texas as we could and do this kind of community information presentation. And a couple of the reasons why I felt like this was a good thing to do came out of our reading of the polls on health reform. So over the period of last summer and up till today, I've been watching the polls every few weeks, and they keep shifting back and forth. More people opposed, more people supporting, more people opposed. Sometimes they're about even. Right now, I think opposed is a little bit ahead, but it's on its way down. And one of the things that I find when we go deeper into the polls is that more than half of the people who respond to these polls, regardless of whether they say they're for it or against it, say that they don't really understand it and need more information. Clearly, it makes you stop and laugh a little bit to realize that people are ready to form a strong opinion despite the fact that they agree that they don't fully understand something. So we thought it would probably be helpful if people had a little bit better information to form those opinions on. Another thing that you should be aware of, and I'm very aware of it when I make presentations because I hear from people on every spectrum of opinion on this new law, is that when you look into the people who say they're against the health reform bill, it's not just the people who wanted things to stay exactly the way they were or think that this bill went too far. It's also a bunch of disappointed single-payer advocates who wish that we had gone to more of a Canadian-type system and are not happy that there's still basically the main way that people will get their health insurance is going to continue to be through private health insurance companies. So Americans' attitudes about this legislation are very complicated, and I hope that our discussion that we have today will help you have a better understanding of how the bill works, and also I will leave you with a lot of places that you can go look for additional detail and information on the pieces of this that interest you the most. It is such a complicated topic. I mean, the healthcare has so many pieces to it, and this legislation does as well, that we figured out very quickly when we started offering to do these presentations that we would tell folks, we're just not going to come unless you give us at least an hour and a half. Because I'm sorry, I can't even say it all in an hour and a half, much less answer any questions. If you don't answer any questions, you just haven't gotten there. So, having said that, I'm going to launch into what will probably be about an hour and a half, and then we will have the opportunity to answer any questions you have, and including going into more detail on certain topics. I actually have some additional slides that will go up the next week. Well, so to get started, because whenever I talk to an audience, I don't know how many different opinions are out there, and I am probably talking to people on every part of that spectrum that I talked about in terms of how they feel about this new law. I always like to at least explain why, as a healthcare advocate, I see this legislation as a huge step in the right direction for our country, even though it has, a long list of flaws, and there are many provisions in it that I'm concerned about. So, having said that, for the first time, this legislation tries to achieve a situation in the United States where everyone, at least everyone who's lawfully present, not undocumented, but everyone who's lawfully present has access to a comprehensive standard of health care, regardless of what their income is. And that doesn't mean that, as you will see soon, doesn't mean that we're going to be providing free care to a lot of people. What it means is that we're going to make sure that people can have access to a decent standard of care, and they're guaranteed that no more than a certain percentage of their income will ultimately have to be devoted to that health care. We'll see the details of that in a few slides. That's a huge change. We've never even tried to do that before in the United States. We've created programs that picked up a handful of people at the very bottom of the economic scale, but they didn't pick up lots of low-income working people, and so that's why we end up with so many uninsured. Now we're trying to figure out a way to make it work across the entire income spectrum. The next thing that is a huge sort of ground-changing development in our healthcare system is changing the health insurance marketplace from one that currently depends to a certain extent on its profitability, on the ability to avoid providing health insurance to sick people, and also on the ability to deny coverage of certain conditions or certain treatments for people who are ill. So it's a big shift in the way the health insurance marketplace works, where you're not going to be able to turn people away, you're not going to be able to charge more because of their health condition, and so if you're going to be profitable, it's going to have to be by being very efficient, by making your customers happy with really good customer service and wanting them to come back, and managing their health care, hopefully keeping their health outcomes better so that your costs are lower and you're more profitable. Those are two huge changes. Those would never have happened by accident. They don't happen in all of the other industrialized countries. They didn't happen by accident there. You have to choose to do those things. So we've chosen to take a step in doing those, but we are a long way from knowing whether we're really going to achieve those goals very smoothly at all. So on top of those two big changes, there are also a whole lot of pieces of this new law that lay the foundation for trying to improve the way we deliver health care in this country. And probably the easiest way to summarize that is, we all know that a few years back, the only way people got insurance was through what they call fee-for-service health insurance, where basically you just turn in the bill and it gets paid. And one of the problems we had was that meant that various folks in the world of healthcare could make money just by cranking out a lot of procedures or tests or whatever, regardless of whether they were helping your health or were what you really needed. And that caused healthcare costs to get too high. So then, a couple of decades ago, we started trying a managed care approach, which unfortunately, the way we did it, also gave people incentives to make money by denying people care that they may have actually needed to be healthy. So we had not yet found a way of financing, providing financial incentives in the healthcare world that lines up with what we want in terms of people getting the best health care, getting it early, not getting things that have been proven to not work, et cetera, et cetera. That's the holy grail. We're not there yet, and this bill is certainly not going to get us here next year or the year after that. It does lay out a whole bunch of tracks in which we are moving forward on that front. That's good news because no matter where you are in the political spectrum, there's pretty much that's getting our healthcare spending, and that means all of our healthcare spending, not just Medicare, not just Medicaid, not just private insurance, but the entire spectrum. Getting that under control, making that a smaller percentage of our total national output is a big goal, and it's a big part of what we have to do to get our federal deficits and debt under control. So, the next thing that it's really important to try to wrap our heads around to get a basic understanding of health reform is the big picture timeline. So there are provisions that are already taking effect. There are some health insurance industry reforms that have already started this year. We'll talk about some of them in a minute. They're not going to cover huge numbers of currently uninsured people. They will cover some, and you'll see that they're sort of targeted to some of the folks who are either paying some of the highest costs right now or most likely to be completely excluded right now. And we'll walk through that in a second. But the other things that are starting right now and next year are basically building up systems to prepare for a bigger expansion of coverage to cover more of our uninsured people. So basically what you're going to see as we go through this presentation is that there's going to be a number of new ways that people can get private insurance by making it affordable and making sure they can't be turned down for it, and also an expansion of public coverage through Medicaid. And neither system is ready to do that overnight. So there are preparations that have to be made, and basically those are also some of the things that are rolling out as we speak. And we're going to walk through some of those. But the large expansion of coverage to try to reach more of our uninsured starts in January 2014. So some of the things that are happening in the first year, and some of this got a little bit of publicity in the last few weeks, because September 23rd was the 6-month point from when the bill was signed into law. So a number of these provisions started taking effect after September 23rd when the bill was 6 months into law. One of the first ones, which applies to all health insurance policies, whether they're individual, group policies, or even self-insured plans, is an end to lifetime dollar caps in health insurance policies. And that is, you probably don't know anyone who's been affected by that. It tends to only affect people with very grave and very expensive illnesses. Some of the first people I ever encountered were kids with hemophilia. A kid with hemophilia could hit $1 million or $1.5 million lifetime limit before he reaches the age of 15 easily. There are other folks with transplant conditions and some of the more expensive kinds of cancer treatments that might also hit limits. A generous employer-sponsored plan will seldom have a limit that's less than $1 million, $1.5 million, maybe $2 million. But there are some health insurance policies that are way more stripped down, sometimes get referred to as mini-med policies, and of course, this would be very different for them. But most of us probably, if there is a lifetime limit on our coverage, we may not even be aware of it. But if you're somebody who's faced it, it can be a very big change for you. They're also rolling out a policy where children can't be either denied coverage or have a waiting period imposed on them before a certain condition they have to be treated. And that's, again, just for under age 19. There's a little bit of a cracking down on arbitrary cancellation of coverage. We haven't heard a lot of news and problems about that in Texas. In some states it's been more of a problem. But basically, particularly when people buy an individual policy directly from an insurer and not through their job, there have been cases where once somebody got sick or injured, the insurance company would go back and start looking at that original application that they filed when they first bought the plan, and they would see that they neglected to tell them about their hangnail surgery back in 1985. And so now we decided that you defrauded us when you originally applied for this coverage, and so we're going to cancel your policy now and not cover your claims. Basically, what this new change in law says is that that's not going to be done on that phony a basis. But if there is a real case of fraud, it can be canceled, but they're going to be looking very closely at that to make sure that policies aren't canceled for innocent mistakes or fairly trivial omissions from an original application. And then finally, on that list of things that apply to all the plans is one that you may have heard about. I think it probably got more media coverage than some of the other ones. And it's also one that probably, I think in terms of numbers, affects probably more people than any of these other early changes, and that is the ability to keep your older children on your group insurance policy until they hit their 26th birthday. And just about every state had some kind of extension into early adulthood on their group coverage laws, but it was different in every state. Not every state had the same kinds of coverage. And what this basically does, it says that as long as your young adult offspring has not hit age 26 yet, you can carry them on that policy. Even if they're married, even if you don't, even if they are not a dependent on your tax returns anymore, even if they're not in college. So it's much less restrictive than some of the earlier extensions that existed in Texas and other states. And I've just found that in this day and age, there's a lot of kids who went off and recently got like a very good college degree somewhere, and are having an awfully hard time finding a job at some place other than Jason's Deli or Starbucks. And although Starbucks provides health insurance, so I guess it's not a good example, they're having a hard time finding a job where they can get health benefits in this very, very tough economy. So a lot of middle class and even well-to-do families have been breathing a sigh of relief about being able to lend a helping hand to their kids as they try to get started in their adult lives. Now, in addition to those policy changes that apply to all of these plans, there are some policy changes that are just going to start rolling out into new policies. So basically, the policies that are already on the books are in a situation called grandfather. They don't necessarily have to adopt these policies yet. But new plans that people buy or pick up, create for the first time will be including these. And those are some new restrictions on annual limits. So we talked about getting rid of a lifetime dollar limit. This will also it will also crack down a little bit on how tight those annual limits can be without getting rid of them entirely. In addition to that, they're going to start asking new plans or requiring new plans to cover preventive care services without any out-of-pocket costs. And that doesn't mean like any old preventive service that I might decide sounds like something to do or I think that I need. It's things that have to be clinically appropriate and recommended by the U.S. Preventive Care Task Force, and age-appropriate, clinically appropriate, gender-appropriate, that sort of thing. But that's a fairly big change to our benefit structure. A couple of other provisions that take effect this year and next year have to do with the regulation of health insurance costs. And the first one is that for the first time in Texas, our state officials, in partnership with federal officials, will be looking at annual increases, the annual premium increase from year to year in insurance policies. You may not be aware of it, but our Texas Department of Insurance doesn't currently do that. They actually don't have the authority to do it. But now, states will be looking at that, and the federal government will be looking at it. And if an insurance company sends you a 35 or a 60% rate hike, and there will be an opportunity for someone to look at that and say, is that reasonable, and can you document with your actuarial data that this is actually based on your experience and this is a legitimate price increase. In addition to that, starting this year, insurers will have to be reporting to the Texas Department of Insurance and federal authorities what proportion of the premium dollars they take in actually get paid out in medical benefits. So the new standard would be, depending on what kind of health plan they are, they're supposed to pay out anywhere from 80 cents on the dollar to 85 cents on the dollar in health benefits. If they don't, they could be subject to making rebates to whoever paid the premium in the first place. A couple of questions that come up for me is, does that mean 80 to 85% of what I pay? It's like, no. It means everybody who's in that same big insurance plan pool with you on the aggregate, they have to be paying out 80% of the premium dollars. So it's not such a good deal that I'm going to get a rebate every year. The other thing that people ask me about is who gets the rebate. Well, it's whoever paid the premium. So if the employer, for example, was paying 100% of my premium at work, and we did end up in a rebate situation, my employer would get the rebate, not me, because I didn't pay the premium. Some additional things that are taking effect this year. You may have heard of this. This summer, it actually got started in August. A new sort of high-risk pool was created in all 50 states. It's called the Pre-Existing Condition Insurance Plan. And Before this existed, about 2/3 of the states had some kind of high-risk pool, and Texas is one of them. However, our high-risk pool in Texas doesn't have any kind of financial assistance for low-income people, and the way the premiums are set, they actually allow them to set them at 2 times, twice what the average rate would be in the individual insurance marketplace. So sort of twice the average. So it's a very high premium to begin with, and there's no financial assistance. So in practice, our high-risk pool in Texas is working really well for folks who are comfortably compensated. So like there's a lot of doctors and lawyers and brokers and folks like that who get their coverage quite comfortably from our Texas high-risk pool. But it has a high premium and it has high deductibles, and so it has not been especially helpful for lower-income working folks who are medically uninsurable. This new pool is still limited in what it can do. It doesn't have any subsidy dollars in it either, so there's no sliding scale for lower-income folks. It is set up in a different way so that the premiums are designed to be at the average rather than twice the average, so it should be somewhat more affordable. Now, it's only available to folks who've been uninsured for at least 6 months, so you can't just jump out of the existing Texas high-risk pool and into this one. The idea being that they wanted to make sure that this new investment was, basically providing insurance to people who had not been covered before. And there's a link on this website where you can go and learn more about that if you're interested in learning more about that program. In addition, starting this year, we've got small employer tax credits available to small employers, and in this case, every time we say small employer, it has a different number attached to it. In this particular case, we're talking about employers with 25 or fewer workers. There's some new tax credits for up to 1/3 of the premium that are available this year, and I have not looked at this information, but I'm told that it's actually really consumer-friendly and well-written and easy to understand, and it's actually at the IRS's website, which is not necessarily something we can associate customer service with, but apparently they did a really good job on that. Now, in addition to those provisions, there are grants that have been available to states, and I think I skipped over it on the previous slide. The Texas Department of Insurance last summer applied for and got a grant to help them start building the expertise that they need and assistance they need to do those health insurance rate reviews that we were talking about. They also have applied for a grant from the federal government to set up an Office of Health Insurance Consumer Assistance. Our Texas Department of Insurance, in their actual state law that created them, there is nothing in their statute directing them to be a consumer assistance entity. It's not part of their mission. And there was actually some discussion in the 2009 legislative session of adding that to their mission, but it didn't go anywhere. So basically, they have only very limited consumer assistance functions right now, and so they have gotten a grant to start building up some consumer assistance ability. In addition to that, they've applied for a grant to start working on planning a health insurance exchange for Texas, which is going to be kind of a regulated marketplace to handle some of the new coverage that starts in 2014. So we'll talk a little bit more about what that means, but it is good to know, important to understand that our Department of Insurance has applied for and will receive all 3 of those grants. The federal law also launches $11 billion additional investment in community health centers, sometimes referred to as federally qualified health centers. And that is supposedly enough money to double the number of patients that they're currently taking care of across the country. It is not something that gets divvied up state by state according to population. It's competitive, and basically communities and existing centers have to come together and put in basically, apply to get funds to either start a new center or expand a center. So we don't know exactly where those funds are going to go, but I can tell you our Texas community health centers are already hard at work trying to figure out how they can get a lot of it and build their capacity. In addition to that, there's a lot of funding in this legislation to start training more primary care doctors, nurses, and other professionals. I asked my intern to go back through and try to figure out for me how much has already gone out just this summer and in September. I know it's more than $500 million, but I don't have a good running total for you now. I don't suggest that it's enough. I think that a lot of us experience difficulties with provider access whether we're in rural or urban Texas today. And when we move to a world where a whole lot more of our adults have health insurance than do today, we're all going to be dealing with provider shortages if we don't start working on it right now. We'll be talking more about that as we go through the presentation. Now, there are a lot of provisions related to Medicare in this law, even though the new coverage is focused on folks under 65 and who don't have Medicare. And there are a couple of benefit increases for Medicare that I want to talk about first, and then I want to talk about some of the more complicated and sometimes misrepresented issues that have come up around Medicare, which I won't even try to characterize for you until we get there. The first story is that we're starting to slowly, over a 10-year period, phase out the donut hole in the Medicare prescription drug benefit. And looking around the audience, I'm going to guess that some of you know what I'm talking about, and others of you have no idea. And if you're lucky enough to have no idea, I hope that you never have to learn about it, because it's a real pain in the rear to try to explain to people who've never heard of it. But the bottom line is, when Congress created this prescription drug benefit for Medicare in 2006, they created it with this great big hole in it. And basically, once a person gets up to about, I always get the numbers wrong, I want to say about $2,800 worth of drug expenditures, they then hit a so-called donut hole where they don't have any more coverage until they have spent out of their own pockets another $3,600 on drugs. And then if they have that money and get those drugs and get to the other end of that donut hole, then their coverage will at that point kick back in at a very high rate of about 95%. But for folks who don't have any assistance during that donut hole, if they do have high drug costs, it's a real difficulty. Obviously, a great number of seniors will never hit the donut hole if they're relatively healthy or whatever medications they're taking are low cost. But it's been an issue since the bill was passed in 2006 to create the drug benefit. So why did Congress do that? Well, they did it for one reason and one reason only, and that was to get the price tag on that bill down. They wanted to pass a bill with a price tag at a certain target. And that's important to understand, because it's going to help explain a couple of other things on this slide as well, why certain other things don't really make very good sense. So some of the ways that the donut hole is getting closed: last summer they started mailing rebate checks. Everyone who was already in the donut hole for 2010 should have gotten a $250 rebate check last summer. In addition, starting in January, there will be a 50% discount on all brand name drugs for anyone who's in that donut hole. So they negotiated that 50% discount on brand name drugs starting in January. And they negotiated that with the prescription drug industry. Then in addition to that, you've got a rebate check, you've got discounts on brand name drugs. They're going to be followed with discounts on generic drugs, which are already relatively inexpensive anyway. And then the size of that donut hole actually will be closed a little bit more and a little bit more every year until by 2020 it's gone. And I think that anybody who's already in a Medicare Part D plan already knows it, but for those of you who aren't, even closing the donut hole does not make this a free benefit by any means. I mean, people are still paying premiums, they still have a deductible, they still have co-insurance, and they still have co-payments. So it's not going to be a free lunch at the end of 2020. It's just going to be much more affordable and will not have that gaping hole in it. Starting in January of 2011, the same preventive care guidelines that we talked about starting to be applied to new private insurance plans will also be applied in Medicare. And again, that doesn't mean, if I decide that I want some preventive test, I get to go get it. It does have to be clinically indicated. But all of those services that are recommended as A or B by the U.S. Preventive Care Task Force will be covered in Medicare, and they will be covered with no out-of-pocket costs. So there won't be any co-payment, no deductible, no co-insurance on those. Added to that is a new checkup, an annual checkup benefit in Medicare, which will also have no co-insurance, no co-payment, and no deductible. And I think when I talk to younger groups, they have no idea that Medicare didn't cover a checkup. So they're kind of astonished to hear that this is an addition to it. But when you think about those two items, those are both fairly expensive items. And one of the other tasks that I need to go for these and do for these speaking engagements is give you a sense of how much they contribute to the price tag of this bill. And I honestly don't know off the top of my head, but they are fairly significant costs of this legislation, again, despite the fact that it's mostly focused on covering people under age 65. Now, in addition to those new benefits, there's also a bunch of provisions that are designed not to cut Medicare spending below where it is, but to make the rate at which it is growing, the rate of inflation, bring it down. So, for example, to bring it from 6.5% annual inflation down to 5% annual inflation. So there are quite a few programs in this law that are designed to do that. And according to the Medicare actuary, the totality of all those Medicare provisions will extend the solvency of the Medicare Trust Fund by 12 years. So that's the good news. The bad news is, obviously, at the end of those 12 years, there's still a problem. So there's still quite a bit more work to be done on making Medicare fully solvent so that the money coming in and the money going out can balance. Another thing that is often a surprise to younger audiences I talk to is that in addition to only recently adding prescription drugs, that Medicare doesn't cover eyeglasses or hearing aids or long-term care. So, one of the things that they did in this legislation, which does not change that Medicare benefit, but which hopefully will help the current generation of working folks build some more security around aging and acquiring disability from other sources, is the creation of a new community services and supports insurance program. It will be voluntary. It will be payroll deduction based, assuming you have a paycheck, payroll to be deducted from. It will be 100% funded by its premiums, so it's not going to be a government-funded program. And it is not designed to provide nursing home care. It is designed to provide home care. So those kinds of services that right now some Texans can get from Texas Medicaid and programs like the Community Attendant Program and primary home care, non-medical services that help you, get out of bed, activities of daily living supports that people need to help them stay in their homes as long as they possibly can are the kinds of things that this new program will cover, this new insurance program. And it's expected to start in 2012 or 2013, and you will fully vest in 5 years, and access to that benefit will, of course, be dependent on your actual level of disability and the amount of help that you need. So that's some of the additional benefits side of the equation. Now, it's really important to talk about a couple of the fairly high-profile issues that were floating around before this law passed. The first was, you may have heard last spring and on into early summer, you may have heard some doctors suggesting that health reform was cutting their Medicare rates. Well, it was absolutely true that their Medicare rates were in jeopardy, and they were in jeopardy of a serious cut, and a serious cut that needs to be fixed. What wasn't actually the case was that health reform was doing it. Congress, in the Balanced Budget Act of 1997, set in place a formula designed to, with the best of intentions, slow that rate of growth in Medicare physician fees. And it was a badly enough designed formula that somewhere, I forget the exact year, but somewhere about 5 years into that, Congress started putting off whatever those inflation reducing factors were supposed to be. And they put it off, and they put it off, they put it off. They call it kicking the can down the road. So, the time came, for the can to be kicked again, and if it hadn't been kicked, they would have been looking at a 21% rate cut. And you're probably aware that a lot of doctors aren't real thrilled with Medicare rates as it is, and they certainly weren't going to be happy with a 21% rate cut. So, there was really not much chance that Congress wasn't going to do something about it, but they elected not to include it in the health reform bill. Now, some doctors had hoped that they wouldn't just kick the can down the road as part of the health reform bill, but they would actually take this whole formula out of law, and that the doctors would never have to go back to them again about this particular topic again. Why didn't Congress do that? The same reason that there's a donut hole in your Medicare prescription drug benefits. Congress was trying to hit a target of $1 trillion over 10 years. And if they had put the cost of that physician rate fix in that bill, they would have had to toss something else in order to stay under their $1 trillion price target. So they waffled around, and it was probably a good 6 to 8 weeks after the health reform bill was signed into law that they finally did kick the can down the road again so that those rate cuts would not hit. This time they only kicked it for a few months, and I believe that they're going to be revisiting that this month or next month in Congress. So this issue has not gone away, and it is a serious issue, and it's one that Congress needs to address. It's just important to understand that the health reform legislation did not create this problem. The next interesting piece of legislative history, which is yet another example of something that Congress shot itself in the foot with, is the Medicare Advantage situation. And there were some seniors who got letters from insurers saying Congress is cutting your benefits in health reform. Call your congressman and make sure they don't pass this law. So there's always a kernel of truth in these things. And in this case, the history here is that Medicare Advantage plans are basically Medicare HMOs, and only 20 to 25% of Medicare beneficiaries nationwide are in Medicare Advantage plans. When you and I, if we are working age, hear that our employer is putting us in an HMO, choosing HMO coverage, we know it's because our employer wants to spend less money on coverage. But in the case of Medicare Advantage, when Congress set those up, they started paying the HMOs more money than they did for traditional Medicare fee-for-service enrollees. So that today, on average, anybody who's getting Medicare Advantage is getting about 14% more money per person than your traditional Medicare population. And that's about $1,100 a year for each person in Medicare Advantage that they're getting, that the other 75 to 80% of Medicare beneficiaries aren't getting. This morning I went to a conference where the opener was presided over by several judges who all got up and related what happened in your courtroom if your phone went off. But I think everybody got the message. So where were we? Okay, so here Congress is. You've got 20 to 25% of your Medicare beneficiaries getting 14% more, $1,100 a head more than 75 to 80% of your Medicare beneficiaries. We're trying to get Medicare spending under control. We're not trying to spend more on Medicare. So there's not much likelihood that Congress is going to come up with a 14% increase for the 75 or 80% who are not getting that. On the other hand, and frankly, when you explain this conundrum to the average senior who's getting the benefit of the more generous funding, probably most people would understand it and say, yeah, you're right, that's not fair. Because the people getting Medicare Advantage aren't the sickest or the frailest or the ones with the greatest need. They're just the people who happen to live in a part of the country where there was an HMO that thought they could make money in that marketplace, and they went out and they sold it, and they did. So, but if you're somebody who's getting a few extra benefits from your Medicare plan because your plan has additional money for you and they're able to give you more stuff and still make a bigger profit, then you're probably not going to be thrilled about the fact that those benefits are being reduced. But that was really the only option for Congress because, again, they're not going to increase everybody else by 14% or $1,100 a head. What they ended up doing is they phased down over about a 4 or 5 year period, which provides some opportunity for plans to hold on to some of that increase if they do a phenomenally good job of improving the healthcare status of their enrollees. I think it's way too early to know how successful that piece is going to be and whether or not those plans will be able to meet those standards and hold on to some of that. But you will see a ratcheting down. It's not going to happen overnight. Again, it will be over a 4 or 5 year period. But you will see a ratcheting down in areas where there is Medicare Advantage coverage of some of those extra benefits. A cautionary tale about the kinds of corners that Congress can paint itself into. So now, if we move ahead to 2014, again, my perspective here is just to give you the overview of the healthcare coverage, the health insurance coverage parts of this law. We could be here all day long if we wanted to talk about some of the other topics too, but this is where we're going to start. So these are just basically the building blocks. And the first thing to understand is that this is very much built on the current system. I mentioned to you before that some of the people who say they oppose health reform oppose it because they're really unhappy that we didn't talk about the current system. But the vast majority of Americans will be continuing to get their coverage through employer-sponsored insurance, and in most cases that will be from private insurance companies as it is today. In addition to that, there is going to be an expansion of Medicaid coverage. And I say expansion because in Texas it's an expansion. There are a number of states where this is not going to be an expansion because they have already opted to cover more poor adults than we have in Texas. But in Texas today, we cover very few poor parents. For example, literally today there are probably about 2.4 million Texas children who get Medicaid. Only about 150,000 of their parents qualify for Medicaid. So one way to think about what this Medicaid expansion would look like in Texas is that most of the parents of these kids would be picked up on Texas Medicaid. And in addition to that, other adults who are just as poor but don't have dependent children could qualify as well. And I'll show you some rough numbers on that in a couple of slides. Now, the income level that they're talking about is 133%, so it's a third above the poverty line. That's about $29,000 a year for a family of 4 this year. And that's your pre-tax income. That's not your take-home pay, but your pre-tax income. In addition to adding those adults onto Medicaid in Texas, Congress will be increasing Medicaid rates for primary care services up to the Medicare level for a couple of years in hopes that that will make more doctors more willing to take Medicaid patients. As I said, you're probably a lot of you aware that Medicare rates don't fill doctors. Medicaid rates in Texas on average for doctors are about 65% of what Medicare pays. So an increase to the Medicare level is actually a fairly substantial increase if that should happen. And the big question mark that goes along with this provision is Congress provided for this to be paid for 100% with federal dollars for 2 years, but we don't know what will happen after those 2 years. So on top of the existing employer-sponsored coverage and this Medicaid expansion, the next layer is additional reforms to private health insurance market. We'll have some standardization of minimum benefits, and that doesn't mean that they're going to tell you exactly what every benefit has to cover. What it looks like it will likely be is large groups of benefits can't be excluded. So, for example, you will not be able to sell a policy that doesn't cover prescription drugs, or one that doesn't cover physician care, or one that doesn't cover maternity care, or doesn't cover mental health. So it will be requiring that certain big categories of coverage be included in all plans. You'll not be able to charge more based on health status, which is a huge change in the health insurance market. There will be limits on how much more you can charge an older person than a younger person. I keep meaning to rephrase that. Someone else wrote that. But basically, the easiest way to understand that is if it's 2014 and I'm 20 years in, the 20-year-old man, and I go in to buy myself an individual policy, and a 60-year-old man comes in to buy the same individual policy, but the 60-year-old could be charged 3 times as much as the 20-year-old, but no more than 3 times as much. And I can promise you in today's market, the 60-year-old gets charged a lot more than 3 times the younger guy in many, many instances. So even though as a person who is rapidly aging and intends to continue aging, and I would like to see that be even narrower, it is actually a pretty dramatic improvement over the current marketplace. The next provision on this list is no one can be turned down for coverage. So you can't be charged more because you're sick, and you can't be turned down for coverage. These are huge, sweeping changes in how the health insurance marketplace would work. There would be no exclusion of pre-existing conditions. If you've ever tried to buy an individual plan, you may be aware of the fact that they do sell plans where they say, yeah, we're going to cover you, but not your kid's asthma or not for the first year. So that will no longer be allowed in 2014. And they will get rid of those annual and lifetime dollar caps for people of all ages in 2014. Now, where are those particular changes going to be focused? First, in something called health insurance exchanges, which each of the 50 states is empowered to create. Some smaller states may decide to join together on that. We don't know that yet. Since we are such a large state, it seems pretty clear that we're not going to have to join together with anyone else. As I mentioned earlier, our Texas Department of Insurance has already applied for and will be receiving soon a grant to start planning a health insurance exchange. And it's basically a marketplace for buying health insurance. I think everyone anticipates that, like so many other things that we do today, that one way that you get that will be online, but there is also a requirement that those things be available by telephone, in person, and other ways, and on paper, so it will not be a strictly internet-based entity. The notion is to have a marketplace, and they used to tell us, think like Travelocity or Amazon.com for insurance. I think that's sort of the minimum of what you could expect, because we hope that it will be a place where there are some pretty strict standards for how the information is provided so that you can really compare one policy to the next, so you can really understand the value that you're getting from one company or another, where you'll get information about consumer satisfaction with different plans, among other things, as well as potentially health outcomes from different plans, but definitely information that you can understand about the benefits and the cost. One of the big questions will be states that will have the ability to be really consumer advocates when they set up an exchange and really try to fight for the best deal that they can and make sure only the best high quality plans are in the exchange, or they can just pretty much say anybody who wants to, come on in and do business. If the choices are really up to the states on that. So those are not decisions that I can tell you what the answer will be in Texas. Now, who will be getting coverage through this exchange in 2014? It is not something that anyone and everyone could go to. It is there for people who don't have access to employer-sponsored coverage. It is there for small businesses, which in this case definitely means anyone with 50 or fewer full-time equivalent employees. States will have the option to allow employers up to 100 workers in. But again, that's a Texas choice that hasn't been made yet, so I can't tell you what the answer will be. So those would be the entities, the individuals and families and businesses that would first have access through the health insurance exchange. In addition to that, every member of Congress and their staff will be getting their coverage through this exchange as well. Now, for the people those folks who didn't have insurance options and those small businesses who go to the exchange, for the folks who didn't have an employer-sponsored option to go to the exchange, if they are in a family with an income less than 4 times the poverty level, which probably means nothing to you, it's just part of my job to know what it is, so I do, and that is around $88,000 a year before taxes for a family of 4, then you could qualify for some kind of help with your premiums. And the amount of help you get with your premiums depends on your income. So the closer you get to that $88,000, the less help you get. And we'll show you the stair step on that in a minute. In addition to that, there's help with out-of-pocket costs. And one of the reasons that is important for Congress to do here is that the most recent research on bankruptcy in the United States found that, this was for 2006, it found that 58% of bankruptcies in the United States were caused by healthcare costs. But more frighteningly, of those, 78% were the people who had health insurance. So, it's not enough just to have insurance. You need to have some level of certainty about a limit on the exposure on your out-of-pocket costs if you're going to stay out of medical bankruptcy. So, this is something that should help reduce medical bankruptcies. We certainly don't think it's going to eliminate them. It works in 2 ways. The first is, and again, it's a sliding scale in both cases. The first is looking just at your co-payments, your co-insurance, and your deductibles. So if you're at the low end of that income scale, you're just above that Medicaid line, maybe your family makes $31,000 a year for a family of 4, then you're going to have a lower co-insurance, a lower co-payment, and a lower deductible. And it gets a little bit higher as you move up through the income scale from just above Medicaid up to that $88,000 limit. In addition, and that's something that people across the board benefit from, even if they are of sort of average health, because it helps them with sort of routine medical care and prescriptions. But for people who get very sick or have serious injuries in their family, there's also a hard cap on out-of-pocket costs that's also on a sliding scale. So the folks at the lower income will have a lower cap. It gets higher as you move up through the scale. And uninsured folks who are above that $88,000 line for a family of 4, if they don't have access to employer-sponsored coverage, they too can purchase coverage through the health insurance exchange. They don't get premium assistance, but they will, get the same rules, which is they can't be charged more because of health care, they can't be turned away, etc. So, and it will essentially be priced on the same level for them as it is for every other enrollee in the exchange. So you're getting a premium that's based at least on the scale of small businesses, the small business pool. The higher income folks who buy coverage through the exchange without a subsidy would also have the benefit of a hard cap on their out-of-pocket costs. It's tied to the existing standards that were created for medical savings accounts in the United States, and it's one of those numbers that gets updated every year for inflation. But right now, it's around $6,000 for an individual, around $12,000 for a family. I like to say that, in terms of this whole notion of medical bankruptcy, if my husband and I, we don't have any kids at home, if we had to spend $12,000 on health care this year, it would not be a happy year for us. It would definitely be a bad year, but we probably wouldn't have to file bankruptcy over that. But if there were not a cap like that, it could really make a difference for us. So you can see how this will, it does not eliminate personal responsibility by any means, and it certainly doesn't eliminate hardship, but it should reduce the number of medical bankruptcies. Now, the next two bullets on the slide are the two most controversial parts of health reform, and I would say, from my point of view, probably the two most likely to be monkeyed with legislatively in the next few years. This is where we're likely to see some change. The first one is the individual mandate to have coverage. Now, again, this does not get applied. It starts getting phased in 2014, so we don't try to make it a requirement to have insurance until you have this marketplace where you can't be turned away and where you can get financial assistance and this expansion of Medicaid. But we've never had that requirement in the United States before. There are major exceptions to that individual mandate. I'll rattle them off real quick and we'll touch on them one more time. One is if you go to the exchange and if the premium there costs more than 8% of your income, the best deal you can get, then you're exempt from any kind of penalty for being uninsured should you decide to do that. The other is that if you're just too poor to even be subject to filing income taxes, then there's no penalty for you being uninsured. There will be some other financial hardship exceptions and religious exceptions and the like, but that's sort of the gist of it. And we'll talk a little bit more about it before we move on. The other provision that is, and this is, I'm sorry, and if you're not aware of it, you may have heard that there are 20-odd states that have filed challenges to the health reform law. This is real. They're not actually challenging the entire law. They're challenging this for the most part. The individual mandate is the main thing that they're challenging. And so that's, again, why I say it may be one of the most likely to be changed. And we'll talk a little bit more about that in a second. There are also some new requirements for employers. The first thing to understand is that there are no new requirements for any employer with 50 or fewer full-time workers. So true small businesses don't have any new requirements. But businesses with more than 50 workers do, and that's a lot of businesses. So we'll talk a little bit more about that. And sometimes when I talk to audiences, it has never occurred to them before, so it's helpful to point out that no employer in the United States is required to provide health insurance benefits. It is part of a compensation culture that is developed starting around the Second World War, and it's very much how people do business. The better the job, the more likely you are to have a good benefit, but it's not a requirement. No one's required to do that. And this law didn't technically change that. What this law says is if you don't provide coverage to your employees, and your employees go to the exchange, and they qualify for premium assistance and help with your out-of-pocket costs that the taxpayer is going to pay for, then you're going to get a penalty to pay for it. So, it's more complicated than that, of course, but I would say that some of the businesses that I've encountered that have a challenge with that, the best statistics we have from the U.S. Department of Labor are that 92% of Texas businesses with more than 50 workers are providing benefits today. However, if you're in the 8% that isn't, then you've got a major business model change to deal with between now and 2014, unless Congress makes some changes here, if you have more than 50 workers. So, the other thing I left out, a really important thing about that penalty. You only get penalized if one of your uninsured workers, because you didn't provide coverage, goes back, qualifies for financial assistance if that is a full-time worker. So, you can see all the loopholes are probably spinning out for you right now. There's probably a lot of ways that the penalty can be avoided. But I think one of the things to point out is that the vast majority of employers who are providing a standard type employer health insurance benefit today and by that I mean I'm not talking about the McDonald's benefit that was in the paper in the last few days that was $2,000 worth of health care a year maximum. I'm talking about a real health insurance benefit that would pay 80% of the bill at least if you went to the hospital and all those. The vast majority of policies in that range are way above the minimum standard that's set for employers in this. So most employers who are providing a sort of standard traditional health benefit today probably not going to have to change a whole heck of a lot about what they're doing under this law. It really is the employers who are doing no benefits today or who are providing the mini-net kind of benefits like some of our big box stores like to do and some chain fast food stores. And I don't mean to dismiss that. I'm sure that the workers who get those mini-net benefits think that they're better than nothing because they are better than nothing. But that's where the challenges will come in. Not so much for the business that's already providing a more standard kind of benefit. This is my coworker Stacy's favorite slide, but not mine. But it does always remind me to tell you a little bit more about the individual mandate. I think the sort of obvious question becomes, if the individual mandate is so controversial, and if people are challenging it in court, then why did they put it in there? And there's a couple of reasons. The first is that this bill was negotiated heavily with pretty much every big player in the healthcare industry. And the insurance industry, while it still managed to find lots of things to fight about this law, one of the things that they wanted was an individual mandate. Because if they are going to change their market, their business model to one where they can't turn anyone away, no matter how sick they are, and they can't charge them anymore if they're any sicker, then they want all the healthy people in that pool too. Because if you don't do that, if you don't have some way to make healthy people buy their coverage too, then the average cost of insuring all the people who are not so healthy is really high. And that would not be good for the marketplace. So this is the dilemma, is how do we, create a pool that's big enough and has enough healthy people in it that the average price, for sharing that kind of risk with the giant pool is something that we can all stand. Now the flip side of that as a consumer, I don't want to have an individual mandate on me if, number one, it's crummy insurance. So I don't want to be at risk of being penalized for not buying something that I think is a bad product to begin with. I also don't want to be penalized or to have a mandate if the system that I have to go to buy it from is not efficient, not easy to understand, not easy to navigate, not consumer friendly. And I really don't want it if the coverage you're forcing me to buy is not affordable. And so my goal from the consumer advocate side of the world is to try to make those things come true in healthreform. And I'll tell you that I have concerns about all of those. So there's something for everyone to be concerned about in this legislation, even somebody like me who basically thinks it's taking us in the right direction. This is my first attempt to kind of show you a picture of what coverage might look like in 2014 under the structure that we just talked about. So we're going by income tiers. In the first level, there at the bottom, you've got children on the left and adults on the right. So just as today, most of our kids who are under 133% of poverty, and again, that's around $29,000 a year for family of four, are covered by Medicaid, and that would continue. What would be different is that whereas today only a very small number of adults get that Medicaid coverage, those working age, working poor adults with or without kids would also get that coverage at that same income. Then when you go up a little bit above that Medicaid line into the income level where our kids who are in our children's health insurance or CHIP program are enrolled, but under that 2 times the poverty level, which is around $44,000 for a family of four, they'll still have the option of the children's health insurance program for kids. There will also be the option of the health insurance exchange. Now, adults who are in that income range, if they have access to job-based coverage that meets a decent minimum standard, then they're expected to get that coverage there. And only if they don't have that employer-sponsored coverage are they allowed to go to the exchange. Once they go to the exchange for coverage, then they are guaranteed that the premium won't be more than X% of their income. And in this case, the X% is 3% if I'm just above that $29,000 line, and it starts creeping up so that if I'm just under the $44,000 line, I'm up around 6.3% of my income. And it doesn't mean that your premium is going to be exactly 3% or exactly 6.3%. It means that whatever your premium is, it can't go over that amount. And it remains to be seen what those premiums actually will be. And then you can see these next layers. Again, the adults, if there's job-based coverage, that's where they're expected to get their coverage. If not, they can go to the exchange, and the percentage of income that they're expected to be willing to pay for their premiums keeps moving up, so that in that last Later, from $66,000 to $88,000 a year, everyone is expected to be willing to pay up to 9.5% of their annual income for their premiums. And again, like I said before, the folks who are above $88,000 have the ability to buy the coverage through the exchange with all the same protections as the rest of the population. They're just not getting any assistance with those costs. Now, what happens? What kinds of coverage options do you have inside the exchange? Well, that very much remains to be seen, but here's some of the general principles about it. The first, whether it's high deductible or low deductible, basically. So you have your nice sort of Olympic model rating scheme where you've got platinum going down to bronze. The standard employer-sponsored coverage today are providing a lot more than the minimum standard. To make that a little more concrete for you, the minimum standard is bronze. And that would be a plan where the premiums on average cover about 60% of your medical costs, and you, the consumer, have to pay on average 40% out of pocket, like a non-deductible plan, basically. Most Texas employer-sponsored coverage, group coverage in Texas, is in that gold range today. We're expecting it to come down to the micro level. So the main variation when you go to the exchange will be some different companies selling their plan, and they will have these different levels that are just basically, do you want to pay your money up front in the premium, or do you want to risk that you're going to be healthy and take that high deductible plan and be willing to pay more out of pocket later for your point of service? The 4 levels that I have up there are the general ones that most of us in this room would have access to. There will also be another level that's an even higher deductible plan for anyone under age 30, sometimes referred to as young invincibles, to give them the even less expensive coverage that people who think nothing bad can ever happen to them would like to buy. This is a picture that I said I was going to show you that gives you a little bit of an idea of why the statement is made that the vast majority of people still get their coverage from employer-sponsored coverage. The Congressional Budget Office's projection of what health insurance would look like without the new law and what it will look like with the new law in 2019 is up here. This is from their actual document where they score the legislation and what it's going to cost. And basically, you can see that whether we're talking about without reform or with reform, that big giant pink slice of employer-sponsored coverage is the 1,000-pound gorilla that continues to provide most Americans health insurance. Then if you look at that blue slice, you can see that Medicaid shift slice does increase under health reform from covering about 35 million to about 51 million people, because Texas is not the only state that has a lot of adults who aren't covered under Medicaid now, so it is going to make a substantial increase in that total population. Then the next slice over is that bright green slice. I have no idea. Oh, well, you're there. Where did that go? I don't even look at this picture. I've seen it before. Okay, so the bright green slice is, and if there is anybody here who might know where the tech person is, and why my screen just went black? Oh, great. Anyway, the green slice is your uninsured. So you can see that even with health reform, you still have a significant uninsured population. It has dropped to 8% of the population from 19%. Did you just go to sleep on me? Okay. Wake up. So there's still a significant uninsured population in 2019, even under health reform. It's just smaller than it would have been without the law. And then finally, you have your non-group market. That's individual policies purchased by individuals and families directly from an insurance company, and it is still picking up 9% of the market. It is not disappearing by any means, although it is a little bit smaller, just as the employer-sponsored piece is a little bit smaller. This is another slide I'd like to show you about who the uninsured are in Texas today as best we know. The latest census numbers just came out about 3 weeks ago for the year 2009, and there were 6.4 million uninsured Texans in 2009. And if you look at that green slice that's up there around 11 o'clock, that's the only piece of our uninsured population that had incomes above that 4 times poverty level, which is the upper limit for getting help in the exchange. So the majority of Texans who are uninsured today, if it were 2014 now, would qualify for some kind of help with their uninsured status to gain coverage. But there is one big exception to that, and that is undocumented residents. They do not qualify for Medicaid, they don't qualify for CHIP, and they won't qualify for health through the exchange. We don't have good estimates, but the best estimates we have on the undocumented is that somewhere between, say, 1.1 to 1.3 million of these 6.4 million are probably undocumented, so about 1 in 6. So they're not riding the uninsured train, as it were, but that is a big chunk of our uninsured population that's not going to be fixed by this particular law. And then I would point out again that those folks over 4 times the poverty level can also get the coverage through the exchange just without financial assistance. Just a quick reminder that almost all of our uninsured in Texas are working age adults, that in fact just shy of 34%, more than 1 in 3 working age adults in Texas 1964 don't have health insurance. The rate is half that for kids from 0 to 18. And guess why that is? It's because they have Medicaid and CHIP to take care of them, and we don't have the same kinds of options for adults at all in Texas. So this is another way to sort of graphically try to think about what this looks like. If we took those 6.4 million people, and we do literally go into the census data, look at income and age and citizenship status, and figure out how they would sort out under this new structure in 2014. So of those 6.4 million, it looks like about 2.5 million, and that includes both adults and kids, have incomes or uninsured, have incomes below 4 times the poverty level, but don't qualify for Medicaid or CHIP, and they could get coverage with some help through the exchange. Another 700,000 or so could buy coverage through the exchange without financial help. So that's potentially 3.2 million or half of the uninsured getting coverage through the exchange. In addition to that, it looks like there are about 1.3 million of those uninsured who are U.S. citizen adults under 133% of poverty who are uninsured today, and they could qualify for that Medicaid expansion. Now, the health reform law did not change anything about children's eligibility for Medicaid or CHIP, but the experience of states like Illinois and Pennsylvania and Massachusetts that have done big health care coverage expansions is that once they start these expansions, anywhere from 50 to 75% of the people who show up and enroll turn out to be people who were eligible all along before they expanded the program. And that for whatever reason, people just didn't get the message or didn't believe that they were really going to be covered until all of the publicity around those expansions brought them in. And for that reason, we refer to it as the welcome mat effect. So even though we're not expanding eligibility for kids in Medicaid and CHIP, we expect that today, these newest census numbers, we have about 1.2 million uninsured kids in 2009, which is an improvement over the previous year. And we think that somewhere in the neighborhood of 700,000 of those kids are eligible for Medicaid and CHIP right now, but not enrolled. And that's after doing a generous adjustment to take any undocumented kids out of those numbers because they don't qualify. So we could be adding a bunch of kids to our Medicaid program as well, and CHIP, who are already eligible for the program. And then, above and beyond that, according to whatever estimates we have in the Congressional Budget Office's model, the expectation is that somewhere between 1.1 to 1.8 million of those 6.4 million would still be uninsured, even if we were all the way, to full implementation of the health reform law. So who are some of these people who would stay uninsured? The CBO has 2 different ways that they projected it, and one is based on the entire under 65 population, and the other one is based on just the folks who are lawfully present in the United States who are under 65, and that's why we end up with that range of 1.1 to 1.8 million on that slide. So that's one of the things to think about in this equation. But our uninsured population will not just be non-citizens. As I said before, not everyone is subject to an individual mandate penalty. So just to remind you, anyone who would pay more than 8% of their income for premiums doesn't have a penalty. Anyone who makes too low an income to file income taxes would have a penalty, and there will be some additional exceptions as well. So some people who choose to remain uninsured won't have a penalty to give them an incentive to change their behavior potentially, and so they may choose to remain uninsured. In addition, those of us who are subject to the penalty could choose to remain uninsured. For one thing, the penalty itself is only about a sixth of the cost of insurance, and that's probably actually generous because they're talking the penalty that they're going to charge in 2014 or 2016 or 17. I'm comparing to today's average premiums, which will of course be higher. So it's not going to be any more than a sixth of the cost of actually buying coverage. So it's not like they're dinging you for the same cost that you would have paid if you'd gone and gotten that insurance. It's more like they're trying to get your attention and say, hey, wouldn't you rather, buy insurance with this money than give it to the federal government? But the bottom line is there are going to be some people who just object philosophically to doing that. There are going to be people who, but don't need any kind of religious exemption, for example. There are going to be people who just think that it makes more sense not to spend their money that way. And there are going to be other people who are like, every penny I have is going out the door. I can't afford it. I can only afford the penalty. And as an advocate, I have no idea, particularly when we start talking about our lowest income folks and those premium assistance scales that we talked about, I have no idea how adequate they're going to be, what proportion of low income folks and working families are going to feel like that's a good enough deal for them to be able to do it. I can show you the slide when we get into the Q&A section. When you add in the out-of-pocket costs that people can pay and the premium obligations they're supposed to have, someone who hit their out-of-pocket cap at those low incomes, even with the help they're getting, will be putting anywhere from 15 to 20% of their income up towards health care. So it's not a trivial amount of your income that you're being asked to put forward. If you're healthy, you're not going to hit that out-of-pocket limit. But it is a significant amount of money that we're asking people to be prepared to spend. And so it's very, very hard to predict what proportion of people are going to choose to stay uninsured under this new situation. And this is a civil penalty. It's just a tax penalty. No one's going to be taken to jail because they didn't get insurance. I don't even know what to say about that. But it is not. It is clear that some people will make that choice, assuming that the individual mandate survives the next few years of legislative activity. Now, in addition to that, as I said, our undocumented population is not covered by the Medicaid or CHIP now, and they won't be under this. They will not qualify for premium assistance, and they won't even be allowed to buy coverage directly from the exchange at full cost. They're excluded completely from the system. Now, people who are here legally, like people with green cards, legal permanent residents, Texas has excluded them from Medicaid as adults. We cover those children in Medicaid CHIP. And we have excluded them from Medicaid in Texas, and I'll tell you we're one of, I think, only 2 states that does that. But we have, so unless or until the legislature changes that, they won't have access to that Medicaid expansion. People with legal status would have access to the premium assistance through the exchange, however, so they will have some options. Now, there are a number of major new roles for states, and I want to just touch on the high points of them, and in the Q&A, if people have more interest, we can get into more detail. But the big picture of the states have a lot to do with implementing this law, so a lot of these decisions for Texas will get made in Austin. One is clearly, if we're going to do this Medicaid expansion, then our Medicaid eligibility system has to get bigger. It's going to be able to absorb 1.5 million people potentially coming in over a 2-year period. And I'm just throwing out a 2-year period because when we started our CHIP program, it started in May of 2000. It took 24 months for it to grow from 0 to 529,000 kids, which was the maximum it ever hit. It never actually got back to 500. It just recently got back up to 529,000 for the first time. But it took 24 months for that to grow. So everyone who's eligible is not going to show up on day 1 in January 2014 for these programs. But over a couple of years, we will, no doubt, see some steady growth there. Someone in Texas has to create and run a health insurance exchange. Our Department of Insurance has gotten the grant to begin planning for that, but the legislature will determine what entity exactly runs that exchange and puts it together. It has to either be a government-related entity or a nonprofit entity. There's obviously a much bigger role for the Texas Department of Insurance and regulation. Texas essentially, we have regulated solvency of health insurance plans and regulated things about what am I trying to say? that their contracts are clear and honest, and we regulate some of the benefit content in group health insurance plans, but we haven't regulated rates. We haven't regulated the premium. That's why that business about checking the increases every year is totally new work for TDI. So TDI has to build a bunch of new capacity and expertise in order to do some of these different kinds of regulation of health insurance that we haven't done before. In addition, Commissioner Giesland spoke at a conference that we sponsored a couple of weeks ago on implementing health reform in Texas, and one of his main comments was that he just sees this as a massive public education challenge, that there's just lots of public education and consumer systems that has to go on to make this shift to this new system. So I think everyone agrees that we just need more capacity there. And then in blue, I put the notion that we really need to be thinking very seriously about building our healthcare workforce. As I said, you saw the slide that showed us that 1 in 3 working age adults in Texas doesn't have insurance. It stands to reason, unless we have a bunch of empty hospitals and doctors sitting around doing nothing, that we probably don't have all the capacity we need in our healthcare system to deal with the system, even if it only picks up 2/3 of the uninsured. We're going to need more doctors, more nurses, more clinics, and more capacity to serve all of our Texans and to not have shortages. And the challenge we have facing us is, as you know, we're going into a legislative session in January where the legislature is looking at a $15 to $20 billion revenue shortfall as they go in to write the budget. Now, the good news is that none of the coverage starts till 2014, right? So there's no coverage cost in the budget they're about to write. The budget they're about to write is for 2012 and 2013. So what they need money for in the budget that they have to write in January, or start writing in January, is money for TDI to build up their capacity, and money for the Health and Human Services Commission to build up the Medicaid eligibility system. So that's the good news. And the agencies, I'm not going to go through all these numbers for you, but they started asking for some pieces of money in their budget requests, but both TDI and our Health and Human Service Agency have said, this is just the beginning. We're going to come back to you in November or December with a new and bigger number, no doubt. So they haven't really pulled together their estimates of what they think they need to start building these systems. So the costs that come to the state tend to come later. The Medicaid expansion that we talked about for adults, which we said there might be 1.3 million adults who could qualify, and even if they're not going to all show up on day one. Well, the good news again is that the federal government pays for the first 3 years of that 100%. So in 2014, 2015, and 2016, there will be no cost of that Medicaid expansion to the Texas budget. So we've got till 2017 to get our act together and figure out what we're going to do about that. And we will probably need that time. Frankly, while many pieces of this legislation are likely to be changed, I don't know that we're going to see this Medicaid expansion repealed. I would not hang my hat on that, no matter what the outcome of these elections are. But everything in this law potentially could be changed by Congress in years going forward. But in any case, assuming that it stays in place, we don't have those costs until 2017, which is good because we will need it. Now, in 2017, and this is really deep Medicaid stuff, but in 2017, we would start paying a share, and our share would be 5%. So we would pay 5 cents on the dollar, and the Fed would pay 95 cents on the dollar. And the next year, we'd pay 6%, the year after that 7%, and then it would jump to 10% and stay at 10%. Now, right now, to cover a senior or a seriously disabled person or a child on Medicaid, the state puts up 39 cents on the dollar. That's our normal share. So even the worst case share that they're proposing for this expansion group, the 10 cents on the dollar, is, a fourth of what we basically have to pay for our current Medicaid match. So it is a dramatically enhanced federal match. It's way better than the federal match we get for the Children's Health Insurance Program, for example, but it is still a share, and it still is something that we have to plan for in our budget. Now, there's one other piece I need to mention, and that is those welcome mat kids that we were talking about. Those are kids we're supposed to be covering right now. And so we're not going to get any special match rates for them. If they start showing up in higher numbers because of all the word of mouth about health reform or publicity, then we'll just be paying our regular match rate for them. So that could actually start adding cost to our state budget as early as 2014 if we see that so-called welcome mat effect. Now, that's probably a little bit more than you really wanted to know, but I think that these budget questions are important to understand. The feds are picking up the dramatic lion's share of the cost of this, but of course we pay those taxes. The most of it will not be on the state budget, but it's a significant amount of money for the state budget nonetheless, just because these numbers are so big, and it will be something that we have to deal with. If you're interested in more of these numbers, the controller put out a report in June that was very preliminary. She said there are about 70 items that we think will affect either the state budget or the Texas economy. And of those 70, we think we can only make an estimate of about 17 of them right now. So it implies that they're planning on updating it and doing some more. I think the quintessential number that I would point out to you at the very beginning is they look at the numbers that our Texas Health and Human Services Commission has predicted for Medicaid, and they're saying HHSC is predicting that Texas, between 2014 and 2019, would have to spend an extra $5.8 billion on Medicaid because of this bill. And I'll talk about that in a second. But the federal funds that we would get to match that, because of that generous federal match rate, would be $76.3 billion. And so this is one of those, two sides of the coin kind of issues. Some people look at it and go, oh, that's fantastic. We get that giant federal match, all those dollars flowing through our economy that we're not getting now, bringing back our federal tax dollars that are going to other states, et cetera. Other people just see the pipeline and say, if you're a legislator who the most important thing to you is never having to raise taxes for any reason, then you're not going to like it no matter how good a deal it is in terms of the federal match. So that's really kind of what we're looking at. One other thing to look at on this slide is that bottom bullet, and that is beware all these estimates. The Congressional Budget Office in their score assumes that only 57% of those adults who qualify for that new Medicaid coverage would sign up. The Health and Human Services Commission, who came up with that $5.8 billion number, they were assuming that 91% of those adults are going to show up in the very first year, and then it's going to go up to 94%. And frankly, I think both those numbers are very unrealistic. The Kaiser Family Foundation and the Urban Institute have done some research where they're projecting something in the area of 75%. That would be a lot more consistent with current state experience in Medicaid programs and the rates at which adults typically take that coverage. But anyone who tells you they know what the right number is, again, they're either really smart or they're not telling you the truth. But the bottom line is, because these numbers are so big and healthcare is so expensive, the difference between assuming a 57% take-up rate and a 94% take-up rate is billions and billions and billions of dollars. So that's why you see these widely ranging estimates. You guys are probably familiar with this. I'm just going to quickly touch on it. Sometimes when I talk to audiences, there's a confusion about how can you say that a bill costs $1 trillion but is fully paid for? And so this was just an attempt to sort of lay that out and how they did it. That basically, you have some big old costs in this bill, both from those additional benefits to Medicare that we talked about, and especially from both the Medicaid expansion and the premium assistance student health insurance exchanges. Those are the really big costs that are in there. Offsetting those costs are some of the things that we're doing to reduce spending in Medicare, which we'll talk a little bit more about in a second, and new revenues. So some of the new revenues are, you may have heard, there's higher Medicare taxes on individuals and households with incomes above $200,000 or $250,000 a year. There's also new taxes on almost every piece of the healthcare industry, from insurers to drugs to durable medical equipment, on down the line. And part of that is because, obviously, they're going to have a lot more customers. So their potential for profit has gone up, and most of those industries literally negotiated that they would accept certain levels of taxation in return for the new revenues that they know they're going to get. And then, of course, there are those responsibility requirements, the penalties potentially that employers and individuals could pay that would also add a little bit of revenue to the mix. The cost savings that we talked about, the Medicare Advantage piece of the phasing out of that differential that we talked about, and then, again, the target is not to cut Medicare spending below where it is today by any means, but to say, instead of having it grow at 6.5% a year, let's see if we can bring that down closer to 5% a year. It may need to go even lower than that. The bottom line is, we have had enormous difficulty. We've had some successes reducing the rate of cost growth in Medicare, but not anywhere near what we need. And so, as I said before, this is just the beginning of that conversation. It's by no means the end of that conversation. I think at this point, I would love to throw it open for questions. I've got all kinds of additional slides that you can go to answer your specific questions, if you're specific interest. But I wanted to show you this link at the bottom of the page, not like that, and the KaiserFamilyFoundation.org. In addition to our website, which you've got on materials that you have and up on the slide, you can find some Texas-specific material on our website. But nationally, the Kaiser Family Foundation has a lot of good summaries of different pieces. They have a good overview of the health reform bill. They have a 6-page timeline of the health reform bill that I think really helps you kind of understand the order in which things happen and how it works. But they also have, for some of you who, I know some of you want to never think about this ever again, if you can help it, but if you want to read more, there's, for example, an excellent 20-page table of all the provisions that affect Medicare. It will detail exactly how the Medicare Advantage premiums get ratcheted down, etc. So there's a lot of really excellent additional material there that's accessible and understandable, and I would commend that to you. And I believe that our MC has a microphone now.
Hello. Is it on? It's working. Where does electronic medical records fit into the reform system of our medical system?
Well, I'm not going to be able to give you all of the details on it. There's a lot of activity around trying to move to electronic medical records, and some of that money actually went out to a lot of Texas healthcare entities last year as part of the stimulus legislation. There's more activity in this health reform bill, and if you want to read the details about it, that Kaiser Foundation is probably one of the best places I can send you to read more details about it. The big problem, of course, with moving towards electronic medical records is that somebody has to pay for it, and when you start talking about anything from a big healthcare system to an independent private medical practice, a lot of folks don't want to put up that money. Also, we have had some real problems with getting to standardization in those systems, and nobody wants to spend a whole lot of money on electronic medical record system only to find out that it's not compatible with somebody else's requirements. So I am not prepared to give you a good summary of all of the HIT provisions, but I know that you can get a pretty good layout of it at the Kaiser Family Foundation's website.
Thank you.
I understood what you said on individuals. If they go to the exchange and they cannot find a insurance policy that costs less than 8% of their total income, then will they be provided subsidy in order to provide them so they don't have to incur that much of their coverage?
Well, that's the kind of thing that will make your head hurt for me. Let's see if I have this will help me do this. Okay, so if my income, if you look at this slide, if my income is below $55,000 a year, then I'm pretty much guaranteed that I don't have to pay more than 8% of my income. So no one below that income ends up in that line. But if I am above $55,000 a year for my family report, then I could conceivably be in a situation where the cheapest plan, in theory, could cost more than 8% of my income. And if I understand correctly, the one thing I do know that I already told you is I have no penalty for being uninsured in that situation. What my understanding is that the high deductible plan that is available to under 30 folks would be an option to me if I fit that description. So I think that in other words, if I'm at a higher income than that, what does that make me? About 250% of poverty, and the premium assistance that I'm getting is not enough to bring the coverage down below 8%, then that would be the option that would be offered to me through the exchange. Does that make sense? You have another question? Okay. You want to let her, you can shout it out if you want.
So that's the situation now. On the marketplace, I can find a policy with a premium that is less than what's being offered in the exchange.
Oh, these are not premiums we're looking at here. This is, I tried to say this before, but it is a hard thing to wrap your mind around. And until we have some premiums, we're not going to have a good understanding of what this actually looks like. You know, real insurance being actually priced out. But what this says is that if my income is $33,000 a year for my family of four, it doesn't say that I will pay 4% for my premium. It says that I can't be asked to pay any more than that. And so there may be a plan in there that is actually only taking up 2% of my income.
Well, I'm sorry. I don't understand why we focus on the lower income. Because what's happening is seniors that are now becoming more and more, we're going to have to afford this. We're not finding jobs, things of this nature. So my concern is not to be penalized, but I don't do money. So I don't think we have an issue on it.
No, the correct, you wouldn't be penalized. If the coverage is being offered you is more than 8% of your income, then there is no penalty. Yeah. But that's not as good as having insurance. So I think...
If I have insurance, then it's cheaper than what's being offered as the exchange.
Well, there is no exchange yet, so we don't know what that coverage is going to cost.
Now there is. If I'm offered, if I don't have insurance for 6 months, then I can get on that.
No, that's a pre-existing condition, high-risk rule.
Right, that's what I mean.
Okay, that's very different from the health insurance exchange. The premiums in the high-risk pool are very, very high because they are based on a pool of people who have high health conditions. So I'm sorry, you didn't mention that you're in the high-risk pool. That is very different. And I would love to talk to you on the side about it. It may be a little too complicated for us to try to sort through here. And my coworker Stacey Becker obviously be able to sort through some other examples for you because she has greater expertise on that. Yes, ma'am.
I have a question about doctors. Doctors who are growing their practice and accepting new patients every day will still, a very high percentage of them here in Amarillo, refuse to accept new patients who are on Medicare. Is there anything at all in this healthcare reform act that will change that simple fact?
I don't think so, and here's why. I think that there are one thing to understand. The Texas legislature sets Medicaid rates, and the U.S. Congress sets Medicare rates. And doctors aren't happy with either of them. And the only way for them to be higher is for you to pay more taxes. And I'm sorry, there's no other way around that. And that's not to say that there aren't efficiencies that need to happen in both systems. We are definitely wasting money on some things in both programs. But the bottom line is, as long as we tell our elected officials that the most important thing to us is that they not raise our taxes, we can't expect them to pay doctors in Medicare and Medicaid well, because that costs money.
Okay, on the individual mandate, on the first slide it said all Americans are affordable. What's affordable to us, right? And then underneath it, where it says all, it says lawful president of the U.S. Under the individual mandate, it says undocumented immigrants. Is that for legal immigrants? Or what is an undocumented immigrant?
Oh, undocumented is not legal, not lawful president.
Also, something else. The premium assistance for your platinum, which is the best you can get, which is going to cost you more, it's great and everything, but so if you have to get assistance from the government to help you pay for your insurance, what kind of leverage are you going to get?
You would not get, the folks who get I believe that I was just reading about this last night, there's like an infinite amount of reading to be done on this lowest out of it. I believe that the premium assistance is all built on the silver level. So they start at the silver level and they improve above it. So that if you're at the very lowest income, like right above Medicaid, and they assume you cannot pay a lot of money out of pocket, then you will have the lowest out of pocket cost. And then it goes back up to where folks that are in these ranges up here, above 66,000, above 55,000, above 66,000, would be getting that sort of 70-30 plan. Ma'am, there was one other thing I wanted to say about your Medicare physician costs. I was talking to the Texas Pediatric Society not too long ago, a similar kind of presentation, slightly different perspective, and one of the pediatricians who's one of the most conservative ones, and I've known him for years, started giving me a hard time about how there weren't going to be enough Medicaid doctors, and there was this temporary increase in the Medicaid fees was not going to be enough, and all that stuff. And then afterwards, I said, well, I agree with you, but afterwards she came up to me and she said, you know what? I want to make all doctors take Medicaid. And so, even a conservative physician, because she's a conservative physician who takes Medicaid, it annoys her that some of her fellow physicians won't do it. And, I think that the leadership for that kind of change may have to come within the physician community itself. I don't know where that's going to come from. Yes, sir.
If you have an individual that doesn't have employer-sponsored insurance, if I understood you correctly, if they make within 400% of the federal poverty level, they're eligible for some sort of subsidy for coverage through the exchange.
They'll be guaranteed that their premium won't go over a certain percentage of their income.
If that same individual has coverage through an employer but has to pay for their dependent costs, do I understand that they're no longer eligible for any subsidy?
That is complicated, and I think there's part of your question that we may not actually have the right answer to yet.
I've been told that the answer that's true, that if there's employer-sponsored insurance, there is no subsidy.
Well, it's not quite that simple, because employer-sponsored coverage has to meet at least the bronze level of actuarial value.
Well, let's say it does.
And it has to be comprehensive benefit package. So you have to have done those two.
Okay, so let's say it does.
And let's say it does that. Then, for example, if there's spouse and children, if the spouse and dependent share, or if whatever the employee share is exceeds 8.5%, then the family can go to the exchange.
And there's a penalty to the employer for that?
There is a penalty to the employer for that, but it's not as big a penalty as to the employer who doesn't provide insurance at all. It is tied strictly to that family, because you could have a family that's freakishly poor for some reason, and so you could be doing a relatively good job with your coverage package and still have some sort of exceptional folks who would qualify.
I guess what I don't understand is
but I don't fully understand.
Why don't we give the employee the subsidy to use towards their employer-sponsored insurance to pay their dependent premiums? Why force them into the exchange?
I think it's the opposite. I mean, the incentives are to keep the person in the employer plan.
Okay, that's not my understanding, but I just want to wait.
And I think the projections, and I think this is one of the weakest areas of the structure, is the unanswered question about if you have two high-level wage earners in a family and one of them gets an employer-sponsored benefit and the other one doesn't, what does that mean about the other one's ability to go to the exchange? And does that mean that if my husband has kind of a crummy grandfather plan through their big job, and I would rather go to the exchange with the kids and get coverage that will have to cover the kids' vision and dental benefits, for example, I won't have that option. So I think that there are a lot of unanswered questions about that.
Thank you.
I saw on one of your slides that it said Congress would be required to purchase their insurance through the exchange.
Yes, he did.
And so they'll have the same insurance we'll have?
Well, I wouldn't say that. I would say that the insurance that they have will be in the exchange. and it'll probably be platinum. And if you are in a position to where you have access to that level of coverage, then you may get it too. But most of you are not going to get coverage through exchange. Most of you are going to continue to have coverage through employer-sponsored coverage directly that won't be involved with the exchange.
True or false? When the government is the payor, as opposed to compared to private insurance, does it generate more paperwork for our healthcare providers?
Well, there's not supposed to be a lot of paperwork anymore. Most of the stuff is supposed to be done electronically. I don't think that there's one answer to your question. I think there are some aspects. For example, if you talk to a pharmacist, Texas Medicaid has had a great electronic prescription system for a long, long time. Works real well. Other parts of the system don't work well. Doctors are not. I don't think that either Texas Medicaid or Medicare is more paperwork than most private insurers are, but private insurers pay a hell of a lot better in most cases. And so doctors are more willing to put up with their paperwork than they are. But every doctor I know has to hire, a staff of several people, and it's not because they're spending all their time on public program paperwork either. I mean, less than half of Texas doctors are even taking Medicaid patients anymore. It's because every single insurer and every single plan has a different benefit level, and there's no consistency and no predictability. And one of the things that will definitely change under this new model is you won't have a completely different policy for every single person that is your patient, so that you never have any idea what's covered because they were all completely different. So, no, I don't think there's anything necessarily inherently more paperwork about government payers, but I know that there's plenty of examples that I deal with all the time where they do very poorly.
I have a question kind of based on personal experience. If I'm an employee who has insurance covered by my employer, and I am below the poverty level, my kids are on Medicaid, okay? In a way, do I get covered for my out-of-pocket expenses? Is that one it? Or do I have to be within the exchange in order to have that happen? Even though, according to the poverty guidelines, I'm lucky enough my employer gets it, which means that my income is below the poverty guidelines. We have clients like that come in, and myself.
No, sorry, you're talking about right now, not under
right now, when it goes into effect, your employer does pay for your insurance premiums. But the out-of-pocket in exchange, when you're below income levels, you get your out-of-pocket expense paid for. So how's that going to affect me? I could qualify for Medicaid.
Under the new law.
Under the new law. I would be able to qualify under Medicaid for my children would be Medicaid. So my employer...
If your income qualifies you for Medicaid under the new law, then that would be where you would go. Your employer would not have to stop covering you. But you would not have access to the exchange.
I would have dual coverage.
No, you could.
Out-of-pocket.
Medicaid allows you to have dual coverage, and what they would do is go to your employer's coverage first, and then Medicaid would pay your out-of-pocket costs once you became eligible for
That's
Medicaid.
what my question is. Yeah.
But you're in a pretty rare situation. There's not a lot of folks who manage to be eligible for employer-sponsored coverage and Medicaid at the same time. And it probably won't work very well. I mean, I think that particular piece of the bill paying conundrum, when there's two different insurance companies involved, one public and one private, I think anyone in the room who's had that situation can tell you
that's
that.
going to happen because you have a lot of single mothers who they may get paid well, but their children they're in that quandary.
Exactly. No, I hear from moms like that all the time. They're like, where is something for me? I'm a single mom with kids. Where can I get coverage for myself? It certainly doesn't help kids to have moms uninsured.
What might you know about coverage of currently non-traditional services, specifically mental health, rehabilitative services, targeted case management, that's currently covered by carve-out Medicaid or general revenue, but not by private insurance?
Well, I think that obviously none of that coverage under Medicaid is slated to become any less generous. So, don't expect any of that stuff to go away from Medicaid. I don't know that you will see private insurance ever offering that kind of intense and robust service under private insurance, but all of the coverage under the exchange will be subject to sort of meeting the federal mental health parity standard. So you won't have any policies that don't cover mental health, and you won't have arbitrary limits on mental health that are not comparable to those for physical health, and you won't have annual limits, which a lot of dollar limits, those sort of things. So there's an expectation that you will have a much better access, and you also won't have any coverage that doesn't cover prescription drugs. So, there will be a much stronger panel of benefits for people in private coverage with mental health coverage, but I don't know that anybody feels like it's going to, except for, like if you work for a local mental health center or something like that, then, and my dad was a psychiatrist and used to talk about all the people who came to him to get prescriptions because their private insurance had some sort of hard lifetime cap on mental health spending. And so, they had private insurance that would have been great if they had a heart attack, but it wasn't going to do anything for their chronic depression or something like that. So, it will get rid of some of those kinds of problems, but I haven't seen anything that suggested a big expansion of the kind of more intense services that Medicaid is typically funded for today in the private insurance market. I can suggest, maybe after we're done, a couple of sources to go to look in more detail at the mental health provisions, because there's a couple of the national groups that specialize in that. They're, delving into that much more than I had an opportunity to.
Yes. I don't think this is working.
Yeah, I can hear you later on.
Two questions. It was optional whether or not a state had to set up an exchange.
It was optional whether or not the state did it itself. You could either run it yourself. If you choose to, you could ask the federal government.
It was my understanding that our current governor was not going to do that. And so I've been puzzled. When did they make the decision that Texas was going to do it?
Well, I would say technically the legislature made that decision.
So it has not been made.
The state has asked for $1 million grant to start planning the exchange. It's unlikely that our legislature would decide not to do it, because we still have an exchange. It just means we don't control it. It's run by the federal government. And I would think in the current atmosphere there would be a desire to make decisions about what Texas's exchange looks like.
Sometimes you can't make that assumption about this state.
I've been here a while too.
We turned down the workers' comp money, and we are trying to turn down $830 million. So that's just, we turned down CHIP money or send it back to them.
Right.
So that's why while the agency, executive agencies apply for the money, the state has not made a decision.
And that request had to be signed by the governor. The groundwork is laid for moving in that direction. Unless the legislature decides not to create an exchange, that's the direction we're headed in. And one thing that confused people is one of the very first things that rolled out was that temporary high-risk pool that is in all 50 states, the new one that's only for people who've been uninsured for 6 months. And there was really no advantage at all to the state in running that itself, because the feds were going to run it. It doesn't cover huge numbers of people or any money. It was different enough from our existing high-risk pool that it would have been kind of a pain in the rear for the Department of Insurance to try to juggle, two similar pools that weren't exactly the same and had the same rules. And so there was no loss in states deciding not to do that. The consumers in the state still get the same benefit either way. And I think that's sort of set up the expectation a lot of people that maybe Governor Perry would not be applying for these additional grants. But so far, he has signed off on all of it.
Okay. And my other question was, years we've dealt with the issue that most of the insurance, group health insurance providers in Texas do not provide family planning or contraceptive benefits. Will they have to now?
I'm pretty sure There were lots and lots of, as you know, negotiation around the abortion issue in here, but I don't think that there's any provision. I don't remember exactly where the conscience provisions came down on. I mean, there may be some exceptions for insurance plans that are run by Roman Catholic entities. Mm-hmm. But I'm pretty sure that the essential benefits will
Texas never required their group health insurance providers to provide birth control. And that's why I was wondering, in these many med policies, there are a lot of big slaughterhouses and chicken packing and beef packing places where they don't pay their employees more than $10 an hour. They have very minimal current insurance policies, and they never cover family planning, and these are people who need it the most.
Right.
And that's why I'm asking, if everything is being covered, that it's going to be mandated for those who wish to choose it.
So every indication that I have every indication, and it's also, quite frankly, wherever you fall on it is one of the services that has been shown to be one of the most cost effective of all. But I do believe that the essential benefits are expected to include family planning services. What I really don't remember is, what kind of conscience exceptions they're allowing for, like I said, for, say, health plans that are run by Catholic hospitals and that sort of thing.
Well, on behalf again of our Board of Trustees and all the co-sponsors, I want to thank you all for being here, and thank you so much for a wonderful presentation.
And I'm happy to answer some questions.